and welcome to this webinar on trauma care in the times of COVID when resources are limited. Brought to you by ESTES, the European Society for Trauma and Emergency Surgery, in conjunction with our good friends in EATSIG. As always, we want to try and make this as interactive as possible, so please feel free to use the question and answer button at the bottom of your screen. Ask whatever questions you want and we'll try to answer them as we go along. We don't have any poll questions today, so please make the use of that extra time to ask even more questions. I'm going to hand over to my co-moderator, Tina Gaarder, to introduce the speakers to us. Tina.
Good evening and welcome to this webinar, ESTES, and for the first time together with EATSIG, International Association for Trauma Surgery and Intensive Care. And you saw the program, and we said we have a few speakers who will talk about trauma care in times of COVID when resources are challenging or scarce. I have changed the sequence, so we will actually start to set the stage with a case presentation or even two case presentations by my good friend Professor Steve Moeng, who is the Director of Trauma Surgery at Johannesburg General Hospital in South Africa, and he's chairman, an academic head of trauma at the same university, WITS. He has both national and international academic activities with a keen interest in critical care. He's a previous chairman of ATLS in Gauteng. He's the current chairman of the ESTES in South Africa, and he's also the current vice president of Trauma Society of South Africa. So we know that the cases in South Africa are challenging, and there are many of them. And Steve, please, the floor is yours. You have to unmute yourself.
Thank you very much to the colleagues and to everybody. It's good to join you again this afternoon. Let me just get the case up, and then we should be able to start immediately thereafter. Okay. I hope you can see my screen perfectly. And just 1 second, and it will share as we start right now. It's working lively a few seconds ago. Slideshow. Thank you. Can I get going, Tina?
Go ahead.
Thank you very much. Much appreciated. I'm just going to give you some of the other cases again coming from the further south from the South African perspective. And I'm just going to do a slight different talk that will be complemented with an extra talk that will be coming further down south from Stellenbosch side. So for me, I thought maybe the two cases that will be worth discussing for today is the thoracoabdominal gunshots, how they keep us humbled. And I'm hoping that you would follow us throughout, and I'll be asking for some of the questions throughout and make sure that we are all together. First case is Mr. EM. He has sustained multiple gunshot injuries. And from what we know, he was left to lie on the side of his working environment for a while. And by the time they found him, he was almost in extremis. If you look very carefully, he's a young man, works as a security guard, multiple gunshots. And if you can look on this picture on your right side, you can see the markings that are showing you a couple of wounds on the anterior abdomen, as well as more wounds posteriorly. You look at the X-ray, which is a Lodox in between, you can see that he is presenting in that position. And on arrival to our emergency department, we obviously had to take it further on. And I'm sure for most of us at this stage, you should be worried about a number of things. There's no debate that this will be a trauma activation case. There's no debate that you are looking at multiple involvements, including the chest, the arm, as well as the abdomen. And again, the priorities is where should you start first in dealing with this case. He arrives, and I think most of us will follow the ATLS approach. We'll look at the physiological data. Actually, at this stage is revised trauma scores that looks at the Glasgow Coma Scale as well as the respiratory rate, and the blood pressure was not too bad. He was actually in a very compensated state. You could see the pH of 7.34, base excess of -5.1, and a lactate of 4.5 millimoles per liter. Tina, I don't know whether anybody wants to say what their concerns are from the panelists at this stage before I tell you how we manage this patient further, and we'll keep on breaking in between.
I think you're free to challenge any of the panelists.
All right, then I will ask Peep.
I'm the only one
at this stage, Prof. Talving. Yeah.
So your question is, what is the plan, right?
Yeah.
So this guy needs a resuscitation, gets all the lines, and the plan is to go to the operating room. However, we need some radiological workup. You've got a chest X-ray, which doesn't show too much, but that is okay. So he's got a distended abdomen, what I saw on the picture. Does he have a peritonitis?
Yeah, he's not mild, he's mildly tender. He doesn't have an acute overt peritonitis, but he's slightly tender.
Okay, so what about the FAST, the ultrasound?
A FAST, again, when you're looking at the FAST, and I'll tell you what we show. Again, when we're looking at the FAST, there's a bit of fluid in the abdomen, not significant amount of fluid. And again, it will be important in this case as well to look at another site that we will describe a little bit later.
Yeah, the most important site is the pericardial sac, and then the abdo, because abdo I don't care about. He needs laparotomy anyhow. So it doesn't matter if the abdominal ultrasound is positive, the pericardial sac is important.
Thank you very much. I think that will be the thought processes at this stage, that we know we need to go to theater. Maybe we may need to answer the question of which cavity first. When you look at this X-ray, there's no massive hemothoraces bilaterally, but the size of the heart is a bit concerning.
Yes.
And that is one thing that we must keep at the back of our mind. And I agree very well with Prof. Talving. So in this case, the anesthetist was coming on his way. The scan was there within 10 minutes, or not within 10 minutes, within 2 meters from our resus. And we decided to scan him. And if you look very, very carefully around the heart on this picture, you can see that there's actually a bit of fluid around the heart. Not a lot of fluid in the abdomen, a bit of haziness towards the tail of the pancreas. And if you look at other views, there's a bit of small amount of fluid in this abdomen, but this is not liters and liters. And on the other picture on your right, you're looking at fluid inside the bladder. So he's not a patient with multiple fluids. He just has a bit of fluid in the pelvis. And again, what is most important for us is to realize that there is an involvement of the abdomen. We've got gunshots on the anterior abdomen, also lower chest, that are traversing and coming towards the back of the abdomen. And therefore, one way or the other, we are going to need to go to theater. And the question is, which cavity are we thinking about first? Sorry, I interrupted somebody there.
No, Steve, if you go back, I saw the pneumopericardium as well, that it seems to be a bubble of air in the pericardial sac.
Exactly. So that was what was noted, with a bit of air and a little bit of air around it. But certainly at this stage, we needed to be aware that if we are going to that, we need to think about the cavity involving his cardiac area. So I'm just going to summarize. We agree that he needs to go to theater. I'm going to just tell you what we needed to do for him. And the mode was that we were looking at double cavities. We were thinking more towards damage control. And he had injuries to the small bowel, grade 3 injury to the transverse colon. He had an associated liver injury, pancreas injury, and certainly our concern when we saw a bit of blood and a little bit of air in the pericardial sac is that we thought that we needed to do a pericardial window, which was done through the central tendon, and all we found at this stage was a cardiac contusion, and there was no obvious perforation, or there was no obvious hole within that area on the left ventricle side. All it was seeing, you could see the injury very well, and you could see that most of the bleeding around it was from the pericardial fat, as well as a bit of a bruise around the heart. I'm going to stop here at this stage and maybe ask if maybe Diego wants to say a comments of what he thinks he will be doing at this stage of the operation. Your thoughts at the moment, that.
And he went quiet. Diego, unmute.
Elmin, are you able to help me out, please? Professor Steyn?
You're asking for the plan, Steve.
Yeah, I think that,
Yeah.
that one, obviously this is going to be a damage control situation. Physiologically, I'd like to know what's happening. And then just as a matter of interest, did you tell us about peripheral pulses and other injury? I know
they are quite
significant
good.
arm injury there.
Yeah, the upper limb is okay. No obvious significant fractures there. And you are left with what you saw in terms of no massive hemothoraces, a bit of pericardial fluid collection and a bubble of air, plus obvious abdominal injuries.
Steve, I've got a question.
Yes.
Were you comfortable to leave the potential cardiac injury there, just looking through the central tendon and saying, well, the heart is okay?
You're absolutely right. What was issue that the difference with this case is that you could see the injury site very well.
Okay.
So you had a very good view. It was more on the posterior surface. It was not higher up. And if you look at the injury at that area, it was more around the costochondral junction. So it was not like the fourth or the fifth intercostal space. Otherwise, one would have been in big trouble. And the answer would have been to go for the next issue, which would have been to open the rest of the pericardium.
Right. And for the residents, I think we should tell that if there is blood, I think your default plan is sternotomy from there. And in very experienced hands like Steve Moeng, I would say, okay.
Yeah, I always open. Let me reassure you. I prefer to open. This one was a slight, and I don't believe in positive pericardial window unless it's a very old patient and you leave it conservative. Anybody that's fresh trauma, you err on the side of safety. And I think you're absolutely right. And that is the difference with this one. We could see where it was, and it was a shock wave injury that was just on the lateral border. No laceration of the epicardium itself, just a bit of a bruise, and some of the bleeding was coming from the pericardium itself and not from the heart muscles as well. So at this stage, the decision was to leave the pericardial sac in case we were wrong. And post-operatively, you realize that he required some ventilation. We were able to wean him off inotropes, just to answer what Prof. Steyn was asking. And he actually started to improve, and he was planned for a relook. The colon was managed, obviously, as part of damage control, and the stomach was managed as part of damage control. And before we went to relook on day 2, we realized that in theater, what looked like a simple bruise on the tail of the pancreas was looking a bit more worse from the shock wave effect. And whereas initially the distal pancreatectomy was not done, at this stage, there was an obvious evidence that the initial assessment under-evaluated the distal pancreas. And obviously we did a distal pancreatectomy with a drain, and we did a Hartmann colostomy for him. And because of a significant injury there, and the small bowel was anastomosed, and he was taken back to ICU. Any comments at this stage from the panel before we move on to the rest of his hospital stay?
Certainly the tail of the pancreas was done along with splenectomy, right, Steve?
Definitely.
Yeah.
Steve, can I make a question? You said in the previous slide, you said that the pancreas was grade 2, so no involvement of the duct. Had you done any kind of questioning, any kind of radiology between then to find out whether that was the case? Because I would still say that if the duct was not involved, leaving drains there would have been my preference instead of taking the tail out.
Except, I think you're absolutely right. I think it brings a number of issues when you are dealing with a pancreatic injury. One is that sometimes we under-evaluate, and actually on the other side, sometimes we over-evaluate the injury. The second one is that, again, the scanners as well sometimes are not very, very helpful. So at the initial evaluation, it really didn't look like it was deep into the body of the pancreas. It looked like there was more of the bruise, and that's where the drain was left earlier on. But certainly on coming back, it looked a bit more worse, and you could see that the injury extended beyond clinical evaluation earlier on. You remember all we had earlier on was a CT scan, and in between we had not taken him up for another CT scanner. Overall, he had been doing better. He was coming off inotropic, and actually he was successfully extubated. But that message should be clear. Beware of the evaluation with the pancreas, especially with penetrating trauma. Sometimes it's possible to under-evaluate, and other times it is possible to over-evaluate around the head of the pancreas usually, and damage control has helped us so that we don't end up doing massive procedures earlier on. Had we been convinced that it was more significant injury, we would have possibly thought of distal pancreatectomy a lot earlier than what we did at about 36 to 48 hours.
Can I ask a question? Latifi here, a great case. Have you thought on the first day after you decided to do a damage control, did you think of putting a few catheters and do a direct peritoneal resuscitation?
Well, in him, we didn't do it. It's not been our standard approach from the South African perspective. And what we had done, we warmed him up. We did the usual damage control. We did the usual fluid management. And actually, he was doing well. The only thing was just that issue of a slightly saponification, a little bit of worsening of the distal pancreas on going back to theater. The rest of his condition, from the heart, from the chest, from the rest of the small bowel and the colon, were all looking very great. So we did not do that at all.
We have adopted that approach actually now. If any patient undergoes damage control surgery, be it for abdominal catastrophe and or trauma, they will be put on a protocol. And we started, and we have now, by now we have around 15 patients in the last few months.
We look forward to more and more of the experience around it. So from up, yeah, yes, go for it.
There are two questions from the audience.
Yes, let him come, please.
So the first one is anonymous. What would be the priority? First to secure heart and treat the air sac in pericardium and then to stop bleeding? Kindly explain.
Again, you'll see with both of the cases, if we get to do the other one, is that you need to be able to prioritize. In this case, we were comfortable that we would start with the damage control in the abdomen, and immediately after doing the initial control of bleeding and contamination, we were able to move on to the heart. The amount of fluid and pericardial symptoms that were there on initiation of the procedure were not overwhelming enough for us to suggest that the chest had to be opened first. But all the time you need to find that balance very clearly. But this patient for us seemed to have more signs and symptoms from the abdomen more than he had from the cardiac involvement. Totally different from another case that we might discuss a little bit later, where that debate had to be taken a little bit more into details.
Steve, I have one in between, a small question. If the patient had been a little bit sicker so that you would not have sent him to CT scan, would that have changed the sequence? Would that have, how would you have, what sequence would you have chosen for that guy? You had the chest x-ray that looked okay with a big heart, and then you have all the holes in the torso. Where would you have started? What would have been your approach?
If he was more sicker, hypotensive, blood pressure systolic of 60, etc., he would have had 2 IC drains irrespective of that x-ray, because I would have not waited for the x-ray. He would have gone to theater from the trajectory, starting with the laparotomy, and definitely followed with the pericardial window. And if there was more blood in his cardiac window, not only would we have addressed the abdomen, we would have definitely opened up his chest.
This last question from Tim. Hi, Tim. Tim Hardcastle is asking, bowel repair, staple or stitch?
For me, on re-look, in the absence of other contraindication, if there's no edema, if there's no friable bowel, I'm quite comfortable to do a stapled anastomosis. But I think we know all of the multiple papers that have come in terms of the meta-analysis that do what you do best, but also know when staples are not the best of friends. So I run away from staples if there's edema and friable bowel. But if I don't have friable distended bowel, I'm quite happy to do. But whatever you do every time, do it in the middle of the procedure, provided there are no local contraindications. I hope that that answers that question.
Good.
Okay, so just to take it further from then, he continued to do well. And then as you can see, he went off the ventilator. He had a bit of a mild ileus after the procedure, went well, colostomy was functional. And if you look very, very carefully, you can see on the left side of the chest that he's developing a bit of an effusion. On day 8, when he was already awake of extubation, started to feed and everything else, we noticed that his septic markers were starting to turn in the negative direction. The white cell count was increasing. The procalcitonin level was starting to rise up from a much more normal level, which was 0.4 before then, which is slightly higher, but it was what he had on arrival. The renal function was okay. The hemoglobin was okay. And I think at this stage, one needs to ask themselves what is going on and what are their worries and what are their concerns. And maybe if I ask, I don't know whether Oleksandr is able to add anything else as well from his side, just to see what he would be worried about at this stage. Oleksandr? Okay, I think we have a problem with the mic, but certainly you are concerned, and certainly from our point of view, we were worried and we decided to do an abdomen. And I want you to look very, very closely. You can see that that effusion that we are talking about on the left side, you see it on the right side of your screen. You can see that there is a left-sided effusion with a bit of a consolidation. And if you look at the heart, there's a bit of more fluid. The drain in the pericardium had not drained anything for more than 48 hours, less than 50 mils per hour, and was ultimately removed. And you can see a little bit of fluid under those circumstances. And the scanners don't show you very well, but actually he had developed a collection on the distal end of his pancreatectomy site. And then there was a peripancreatic collection. And obviously for most of us at this level, we will be at day 8, be thinking more about radiological intervention. And in this case, we decided to pigtail this patient. And this was a successful management with a pigtail. However, when we thought he was doing very well, it became quite clear that his X-ray was looking more and more widened. And I'm sure you can see over that period of time, his hemodynamics are okay. He initially didn't drain a lot in terms of his abdomen, in terms of the pericardial drain. And lo and behold, at the moment, he's starting to have a worsening in terms of cardiomegaly. Any thoughts at this stage? Does anybody want just to give us any opinion, Raf? Any thought at this stage? What are you worried about?
The fluid around the heart, surely you did a little echo or a scan, ultrasound?
Absolutely. So certainly at this stage, the question is that, is there anything else that we have? And we seeked a cardiology review. And lo and behold, that was a patient that had developed a Dressler syndrome and actually responded very well to non-steroidal anti-inflammatory. The cardiologist decided to do colchicine. The amount of fluid around the heart continued to improve. And actually his abdomen as well improved from the pericardial drain, and he was discharged. And as you can see, this is a follow-up X-ray that shows you a very completely normal heart after the associated significant reaction. And all of that, this required over and above assessment and echo was to give him non-steroidal anti-inflammatories. I'm gonna just give a break for 2 minutes before we move on to the next case, just to hear if there are any other opinions around it. But for us, this was a case that had shown a thoracoabdominal. You can see where the chest injury that had gone into the abdomen was not far from the costochondral junction. And that's why we could have a very good look of the heart from where we were within the abdomen. But certainly an unusual Dressler syndrome, and the patient recovered very well. We're still waiting to sort out and reverse his colostomy. Any comments from the panelists before we move on to a quick case, and then we can wrap up?
Say something?
Steve, my personal compliments about your talks, very great. I have a question for you. Talking about a low resources setting, what's your opinion about ultrasound as a tool for a follow-up in this situation, for effusion, for collection, for any type of drainage?
Thank you very much for that question. I think number one, let me just declare it from the beginning. I love ultrasound a lot. And for most of our units, you will find an ultrasound available in emergency department. So our extension of ultrasound goes even far beyond follow-up. We use it very, very actively as part of our resuscitation. We use it very actively in our ICU. And you are absolutely right. I think there's a role for this kind of a patient. And in this case, we prefer to go echo, but certainly to follow his heart, we were quite comfortable to go and use an ultrasound. For me, when I'm doing a follow-up, as opposed to when I'm resuscitating, I prefer to have a radiologist involved in that follow-up versus when I'm resuscitating, in which case I'm quite comfortable to put pneumothoraces, hemothoraces, cardiac tamponades, fluids in the abdomen, and that comes in with the more cases that you are involved in. So yes, I think it plays a major role. Sometimes it helps us when we don't have other scans and other issues, but does not replace when the scan is really required. But as part of augmenting your clinical follow-up, certainly very, very beautiful extra armamentarium to use.
I have one more quick question from the audience for you. Would you do anything differently looking back? Leave pericardial drain longer? Question mark.
Well, for this one, because it was a Dressler, it was not a complication of a missed injury or something like that. No, we would still follow the drain and remove it following the amount that comes out of it. And again, one has to be careful on how you insert that drain. You don't want to end up with abdominal complication and sepsis around the pericardium. But very, very interesting question indeed. If this patient, we would never have removed that drain if it had blood in it. We would have then realized that we made a mistake and we should have opened him up earlier. But this patient, within 24 hours, he was serious fluid coming out of that drain. It was clear, it was draining, it was not blocked, and it did very well. But the Dressler syndrome has nothing to do with the drainage itself. The Dressler syndrome, as you can see, developed about 3 weeks to almost near a month while he was in hospital. And this is what we are seeing. It had nothing to do with development of effusion within 48 hours or something like that post-admission.
Frank is congratulating you on having a colostomy quite lateral to this because of the damage control. Question for you from me then is, when do you actually offer them to take down the colostomy?
Well, from our side, again, we would like to do them. We prefer to do them between 3 and 4 months. We've been unfortunately interrupted with COVID, and some of our hospitals closed, and you are not able to bring patients in for procedures until the numbers are better. But certainly at about 4 to 6 months, if they are well enough, I'll err more towards the 4. If they were sick and were in ICU and having all the peaks and all of the other syndromes, then I might wait for them to really do nutritionally better and come round about towards 6 months. but that will be our general guideline. And then once in a while, a curveball from an open abdomen might actually make you plan a little bit more efficiently than that.
I guess in COVID time, those colostomies will stay for a pretty long time.
Yeah, he's ready to have his reversed. Can I quickly go to the next quick case, and then is that okay, Tina, through you?
It's possible for us to go because we're running now half an hour.
Okay.
I'll do the talks first, and then if we have time, then we run.
With pleasure. With pleasure. Thank you very much.
Thank you so much so far, Steve, and we'll look forward to the last case at the end. In the meantime, I'm going to introduce another friend, Professor Elmin Steyn, who is a trauma and transplant surgeon, who is heading the Division of Surgery at the Faculty of Health Sciences of Stellenbosch University in Cape Town, South Africa as well, and is head of surgery at Tygerberg Hospital. She is the current president of Ayatsik, and she is also heavily involved in trauma care and teaching, all different levels in many, many countries. And we look forward to Elmin's view on trauma care in times of COVID when resources are limited. Thank you. The floor is yours. Well, the screen is yours.
Okay, can you hear me now?
Yeah.
Yes? Right, so I'm going to talk about the task I was given was COVID in resource challenged or low resource environment. And I must say, I really am looking forward to whoever is going to make the movie about trauma in the time of COVID. I can already see that movie. It's going to happen. We are really fortunate, and I don't see why I can't forward my slide now. There we go. So when I started with the presentation, I was still thinking in terms of low and high income countries, and I've got a problem with that nowadays. I don't think we should use those terms anymore in trauma, because it's changed so much, and countries that used to be low income countries are now middle to high income countries like China and Botswana and Vietnam. And by simply opposing low and high income countries, we're actually doing an injustice to the knowledge and experience that's built up in the less privileged or less affluent countries. Because I think that trauma care can be really pathetic in some high income countries and can be really excellent in some low income countries. So we need to get away from that a little bit. But ultimately, it's about the, I'm sorry, that slipped. It's about the fact that the trauma care and COVID are competing for resources. And both very privileged and very rich countries, as well as low income countries or countries with less resources, or shall I say systems with less resources, have to be extremely careful about the utilization of what they have. Whether you have a lot or little, you still need to utilize your resources well. And I think trauma and COVID together is exposing a lot of the weaknesses that are already prevalent in our systems. Unfortunately, like trauma, the patients with COVID are disproportionately less likely to do well when they are from less affluent communities. And that has been shown even, especially in some of the high income countries, that patients of color and persons of less affluent communities are likely to do worse. And ultimately, when patients are injured and in the time of COVID, we see that there is a disadvantage to serious trauma cases. All of this has a very big ethical background, which I'm not going to go into great detail, but ultimately the ethicists, and there are plenty of publications on this, are adamant that there should be no difference in allocating these scarce resources to COVID patients as well as to other medical conditions. But as surgeons, we know that's not true. As surgeons, we know that a lot of comorbidities, a lot of collateral damage sorry, not comorbidities, collateral damage has occurred, and our acutely ill and subacutely ill surgical patients are paying the price for COVID because they are not getting their cancer surgery. And in the case of trauma patients, where they may be getting their emergency surgery, they're not getting the same access to critical care as previously. So there are principles, ethical principles, very sound and well accepted ethical principles that we can all utilize when it comes to competing needs for resources. But some of them are really hard to apply because we all want to utilize the principle of maximum benefit. So the patients who are maximally going to benefit are, of course, the ones that need the critical care resource. People need to be treated equally, of course, and prioritize the sickest, yes, of course. But when you compare a seriously ill COVID patient to a seriously ill trauma patient, especially post-op, it's not very easy to compare them because there are different factors that are not easily equalized. And unfortunately, in the time of COVID, we found that there's a lot more sympathy with the COVID providers. The physicians have their moment in the sunshine at the moment, and the trauma patients generally are taking a back seat in many of the places that I'm aware of. So we know that trauma patients are from a high-risk background, and that the causes of injuries are internationally very much the same, but in low resource economies, there are additional risk factors that contribute to the likelihood of people getting injured. Now, this is not easy to correlate with the role of COVID. The risk factors are still there. We know that they're worse. People are economically disempowered. They are more likely to be hungry. They're more likely to be stuck at home during lockdown periods. And we assume that this will contribute to the transmission of COVID and to the difficulties of these patients get to medical care if they were injured. But there's very little direct evidence that can be shown. At the same time, we're looking at barriers to trauma care, and we know from many publications that there in the resource-challenged environment, there are more barriers. People are, it's more difficult to get to places of care. It's more difficult to get proper treatment for patients in really challenged environments. And again, we assume that COVID would make these conditions even worse, would impact on all of these factors, but very little evidence that one can show at the moment. But what we do know, and this is one publication that was from November last year that reviewed about 30,000 patients from all over the world, is most institutions report an increased interpersonal violence, increased self-harm, and increased pediatric injuries. People at home, people are depressed, and people are frustrated. At the same time, most of the world experienced a decrease in traffic collisions and sports injuries. And in general, there was no real significant change in the care of the injured. So this does seem to be fairly good news. If we look at trauma worldwide, there's less trauma, apart from some interpersonal violence that increased. And the care of the injured was still adequate and sufficient. Although this may not be true for a lot of the low resource countries. Looking at this study from KwaZulu-Natal in South Africa, it was clearly shown how dramatically the injuries were reduced during our lockdown time. Now, it's important to know that our lockdown period, which was from March until about August last year, and now recently again, was associated with a complete ban on alcohol sale, alcohol transport, alcohol alcohol provision was really stopped. And although a few people did have a little bit of supplies at home, that ran out pretty soon. And there was a dramatic drop in alcohol usage in our country, apart from the travel ban and stay-at-home ban. So taking alcohol out of the equation made a huge difference to injuries, and notably also interpersonal violence, which in countries like the US increased when there was lockdown. In South Africa, it certainly dropped dramatically. So somehow everybody suddenly realized how important a role alcohol plays in the number of injuries and trauma that we do see. This is a report from Kurihara Hospital, my colleagues in Cape Town, University of Cape Town, and showing exactly the same, a significant proportional reduction in violent injuries, the role of alcohol clearly revealed, and they report a significant increase in gunshot wounds, which occurred shortly after the release of lockdown. My own hospital is a very high throughput trauma load with blunt and penetrating assault, one of our biggest headaches. And we also saw some significant changes in the patterns. For example, if you look at the blue pattern there, that is the weekend peaks of trauma, which are very much related to alcohol abuse over the weekends from our local citizens. And the red line outlines where there was a significant ban of alcohol use, and we saw a really nice flattening of those peaks, which again, once the alcohol was made available again, came back. An interesting thing for us was in the early stages when COVID was still quite, shall I say, limited. The lockdown was immediately made compulsory, and alcohol use was not available, and the complete total all causes deaths dropped. So while COVID deaths were not yet obvious, the country experienced a significant drop in the death rate. And this was because there was so much less trauma deaths. And indeed, on the right-hand side, you can see that our natural deaths, that's the black line, dropped significantly during COVID lockdown. So this was a great evidence that COVID lockdown prevents trauma deaths, which was good to know. This is just to show that, unfortunately, it's not just good news. We saw a very worrying increase in gunshot injuries in the later months of COVID lockdown, and almost a doubling of gunshots was seen from June, July, August, September last year. And this, although the other causes of injury dropped significantly initially, we found that gunshots increased significantly after that. Of course, the role of alcohol was exposed, and everybody suddenly realized something that the trauma surgeons have been saying for many years, is that alcohol is out of control and creating a very costly burden to the healthcare system in South Africa. And maybe this is one of the better spin-offs of the whole of COVID and lockdown, is that there's such an awareness now about the dangers and the consequences of alcohol abuse and the expense that creates for our healthcare system, that hopefully there will be better controls. Unfortunately, this is also paradoxical because, especially in Cape Town, the hospitality industry, the wine farms, the cultivation of wine and grapes is a very big part of the economy, and tourism and lovely restaurants, all of those are based on alcohol selling and alcohol availability, and there's going to be significant conflict if alcohol is not allowed. Right, so the surgical aspects of what we experienced also was significantly compromised by the COVID challenges. The resource challenges really was significant here. Although the overall numbers of injuries were less, our surgical procedures were not less. And this was especially due to the fact that we had lots of gunshot wounds. And often they presented late. There was a need for critical care, which was not always available because of COVID taking over every single intensive care bed. And of course, our anesthetists and our theatre staff were deployed to the critical care wards, where they had to help with the COVID patient management. And that made theatre access and critical care access much more difficult. In particular, we had challenges where trauma patients were also COVID positive, whether they were ill or just incidental positivity, created challenges that was not anticipated initially when the protocols were designed. And this further compromised the access for trauma patients to critical care. So what have we learned? We learned that COVID lockdown reduces trauma and unnatural deaths in South Africa specifically, and probably in other parts of the world as well. Unfortunately, gunshot wounds increased dramatically in Cape Town, and emergency surgery requirements did not change. We needed to do the same number of surgeries. Access to critical care is severely curtailed, and this is an ethical dilemma that is not quite solved yet. And I think that the collateral damage from COVID, the patients who were compromised in their care, not because they were COVID positive, but because they couldn't get access to theatres or to critical care, that is very difficult to measure. It happened both in the cancer category as well as in the trauma patients, and we find it really hard to measure that kind of outcomes. Ultimately, we need to plan ahead, because in Africa today, we're only counting perhaps, I don't know, a very small amount of the actual number of COVID patients. And because vaccination rollout has been delayed and further delayed now, today we heard, we can expect a third wave. And we really should be preparing even better. And we know that the equitable access to critical care beds is one of our biggest challenges, especially now for COVID positive trauma patients, which certainly will be more in future. And a specific issue that I would like to hear some experience, whether you guys have experience with that, is where as time goes on, more and more people in the population are now historically, but still COVID positive. So they've had it, they're not actively ill, but they're still testing positive. Now they present with injuries. And because they have a positive test, we are still stuck to triage protocols where COVID positive patients are treated differently. And how to deal with this is going to be a problem for us from now on. So that's our experience. Some of it is applicable to many other countries, I think. Some of it is unique to Cape Town and its gangster problem. But I thank you for listening.
Thank you so much, Elmin. That's very nicely described a lot of the really, really heavy challenges where we are facing and you are facing, a little bit in different versions. I'm going to open for comments from the panel or questions. I can actually, I will start you out with the one question in the question and answer. What should be done to reduce the interpersonal cases? This is, you have half an hour. What should be done to reduce interpersonal cases and the gunshot incidences that increased after the lockdown, as the speaker mentioned? How the collateral damage should be addressed?
Well, you know, these are two different things. Interpersonal violence is very much alcohol-driven, weekend activities. And there is now a lot of attention to this, and a lot of regulations can be set up to limit access to alcohol, especially for the youth, better control. It's not easy because it's culture. It's a culture of abuse of alcohol. That is alcohol binging culture, which is very common, even among students, and not only in people who come to Tygerberg Hospital, but in people who all over this country. So it is a big thing. It's going to be extremely difficult. There are some regulations that can be applied, but it's multifaceted. The issue about gunshots is a completely different one, and that is the issue of crime, of organized crime, and a gang economy. And as the COVID lockdown clamped down on economic activities, of course, the criminal economy, which consists of smuggling of drugs and various other things, flourished. Because when alcohol is not available, even cigarettes were banned, the criminals don't mind. They take over the gap. And that opens up competition, and competition in the criminal environment of Cape Town leads to a little bit more violent dealings with the competition. So the surge in gunshots is very much based on the gang culture, and that is based on organized crime, which has its own roots and its own background. Also not easily dealt with, but we're hoping that that our police service will come to the party. Yeah.
There is a comment from Denis. He's asking, how do trauma patients do when they get COVID while being in hospital? Iatrogenic transmission from nurses, for example? Anyone?
Well, yeah, we don't have a lot of evidence of that. I think Denis may have experience of that. Our patients, yeah, they come and go. But you know, it's very difficult to determine whether they got it in hospital. We haven't got many of those, as far as I know. But you know, they're in there as just like all the others, and I think maybe Denis knows more about those patients.
In the meantime, I think I'll just ask the panel. I think Steve, you have a comment, maybe?
Yeah, that was a quick one. I think from our side, for a long time, we've been doing swabbing, not just relying on the screening on admission. And I can assure you very, very few of patients got positive in hospital. So automatically when they arrive, they are swabbed, and then they are sent to a PUI. And if they are positive, they go to a COVID ward. However, you would once, you know, in a long time, find where the healthcare workers might not have followed the usual protocol. And you might find somebody closer, but that will be a very unusual number of patients that tend positive under hospital. It's either they usually already came in positive, or they remained negative for most of their stay with us.
I have one comment from Tim, and he says, we keep trauma patients in the usual place and only move them to the COVID unit if they're positive after initial treatment. Those more than 10 days post-COVID diagnosis and asymptomatic go back to the COVID negative areas, including the normal theaters. That's from Tim. And then there's a question about how you deal with surgical training during this period, knowing that it might be difficult already without the pandemic.
Yeah, the training has been really challenging. I must say our residents were amazing. They did their share, and things went on as usual. When it comes to medical students, of course, they lost out because they were really not much in the wards. I think that medical student training last year was certainly very theoretical, shall I put it like that. Online medical student training, not the best. I think that I'm not quite sure exactly what the question is, but I think in terms of training, formal training continued. And for us, it was more challenging, but we managed to train. And I think the surgical exposure that our residents had, perhaps not so much elective surgery, but there was always enough trauma surgery. And of course, we'd had as much as we possibly could, the urgent cancer surgery, but not enough of that, unfortunately. But I don't think training suffered as much as training suffered for disciplines like ear, nose and throat surgery or plastic surgery. I think there the training exposure was significantly reduced for those surgical trainees. Thanks.
Okay, I am going to stop this now because we'll have to move on, and I'm going to introduce the next speaker. Before I do that, I am a bad hostess having forgotten to introduce also the panelist. We were supposed to have 2 panelists from the invitation, and that was Luke Leenen, who is from the University of Utrecht. He has sadly not been able to join us, but we do have Professor Peep Talving, who's at the University of Tartu in Estonia, who's Chief of Division of Acute Care Surgery in North Estonia Medical Center. And he has a long time background from LA County Hospital, and he's also the chair of the Educational Committee in ESTES. I am then pleased to introduce the next speaker, and we have the fortune to have Oleksandr Linchevskyy. I think my pronunciation is not good enough. He is a cardiothoracic surgeon from Ukraine. He was until very recently the Deputy Minister of Health in Ukraine, and he is the first Deputy Director of the Medical Center Obrik in Kiev. When he was the Deputy Minister of Health, he was responsible for the reform of medical education, introduced the principles of evidence-based medicine in Ukraine, and coordinated the work of the Directorate of Medical Services. And we're looking forward to hearing what you have to say about COVID and challenges in Ukraine. Are you able to share your screen with us?
Yes, I'm trying.
Yeah.
Great. So it's okay.
Yeah, we see you.
Trauma care in time of COVID. So in Kiev, in the capital of Ukraine, we have 3 million population and 2 dedicated hospitals to treat multiple trauma. We observed considerable reduced the number of trauma patients and trauma resources were secured, were untouchable. So trauma surgeons in these circumstances were bored, and I will try to show you why. So it's our lesson learned. I will share our state, not just not my personal, but my state, my government failures, my government mistakes in COVID time. In the first slide, our lesson learned, the first, it's don't underestimate the threat, don't doubt science, and don't breach the trust. Just after the first lockdown, it was really tough, really robust lockdown. Everything was completely closed. So it seemed to be quite successful. We compared our results, our numbers of patients with COVID, we compared them to numbers from Italy, from United States, and we were quite happy. Government allocated about 2 billion euros for COVID fighting. But with these numbers, with this success after the first lockdown, government spent money to infrastructure, for building of roads, for supporting different groups of workers and so on. And you can see on this slide how small was amount of money spent on hospital support, on especially for personal protective equipment, for oxygen delivery, oxygen ventilators, masks, and so on. In proportionally small amount of money was spent for hospital. And then the true avalanche of COVID came to us. As you can see, in the fall, we had a real tsunami of COVID patients in unprepared hospital. You can see on the right scale, it's a number, right scale, and the blue line, it's a number of number of tests, and we as a country were able to provide only 45,000 tests per day. Right now, United Kingdom provide 800,000 tests per day. So we will provide only 45,000 per day with a great, huge positive rate. About 36% were positive. So in fact, we just confirmed COVID in hospitalized patients. Testing in Ukraine didn't work to prevent, to isolate contact person and so on. What else? It's a true pictures from a hospital near the Ukrainian capital. It's improvised oxygen ventilator. It's improvised oxygen delivery, handmade, and government and the country as a state were unable to deliver oxygen to hospital, to deliver enough oxygen to our patients, and non-governmental organization bought and delivered some kind of concentrators and ventilators to hospital. The second lesson learned, don't doubt in science, especially in panic. You can see a lot of guidelines, a lot of available guidelines says advise not to use several medications to treat COVID, especially don't use hydroxychloroquine plus azithromycin to treat COVID. But when we are in panic, we are exposed to any source of information. And after this tweet, especially after this tweet, people usually trust United States. And when the President of the United States says use hydroxychloroquine and azithromycin, we did it. You can see on the on this slide the level of in-hospital use of azithromycin almost doubled or tripled only for 9 months of the last year. So we used non-evidence-based advice, and we used a lot of medication which didn't do something good for our patients, or even probably we do some harm for our patient, including this combination of drugs in national protocols for COVID. And the third lesson learned: don't breach the trust. Don't confuse don't confuse patients. Don't confuse people. You can see two pictures. It's a sad. It was available everywhere, and every media shared it. You can see a dozen of policemen chased a guy who was in a Dnipro river in Kiev because it was surprisingly it was forbidden to go to a beach. And on the second picture, you can see Ukrainian president who at the same time takes coffee in a cafe in time of very tough and robust lockdown. And these facts confused people a lot. It was our internal problem, internal cause of confuse. But we suffered a lot from external causes. As Ukrainian speaks Russian perfect, we are living in a Russian media atmosphere, in a Russian media, under Russian media influence. We were exposed to a lot of fake news, to a lot of fake ideas about COVID. And we could not fight this fake news, fake statements, fake rumors, and so on, and even fake pictures. We completely failed this fight. Even right now, it's a sociological study from the January 2021. You can see a half of Ukrainians refused to be vaccinated even now because we failed the informational war. We failed maintaining a trust between professionals and patients. And the last slide, you can see the curve, you can see the line of extra mortality in Ukraine in 2020. 0, it's a 5-year average. You can see the role of COVID death in the overall mortality and the extra death. And some numbers. So we are on 8th place in Europe, total case, total death. Unfortunately, we are on a 109th place involved for testing per capita. And for the day, for the 8th February, we did zero vaccination in Ukraine. And this is the end of presentation, but probably this is not the end of the whole story. But in trauma, fortunately, we have no limitation of resources, and trauma surgeons are were bored this year. Thank you.
Thank you so much, Oleksandr. Again, I will open for some comments or questions from the speakers of the panel or from the floor. I think it's a very honest and somehow frustrated story, frustrating and frustrated story. You've been very close to the Ministry of Health. You have been part of the Ministry of Health. Yes, you were. So how is that? Say how are you able to influence any of this, or how does your background as part of the ministry, how does it allow you to be part of a strategy or to help out or to influence?
Sometimes, we are in we see now some kind of expert failures, some wrong decisions, some incompetence. Unfortunately, we try to work with all political instruments, with pressure from active people, from media. So we are working.
Any other comments, questions?
Oleksandr, fascinating story. Kind of brings some tears in my eyes if I'm thinking of the situation, no testing capability. We're testing everybody admitted to the hospital every 3rd day. And very close to us is a country of Ukraine having no capability of testing. and the communication errors. I think Estonian government was smart enough to include scientists as advisory board from the beginning. So we've been able to give a good advice to the government from the beginning. We're still suffering at the same time. We're having a pretty high burden, but the system is open. We are operating on time-sensitive cases, etc. But I do feel kind of sympathy, and I am kind of burdened with a country of Ukraine suffering that badly.
Elmin, you had a comment, or?
Thank you.
Unmute. You're still muted. Left corner, left lower corner. You're still muted. While you unmute, I will just say, I'll just want to come back to one thing, Oleksandr, and what you said, this the matter of trust, the two photos with the policeman on the beach and so on. I think what we have, I mean, I'm not in a position to say anything here because I think we're in an extreme fortunate situation in Norway at the moment. Or have been all the way, but I think what I've been saying all the way is that it is because we have had clear leadership with involvement of clinicians in the leadership, being seen together with the Prime Minister every single afternoon for more than a year, and they have all the same clear messages. And they all agree when they come out with new restrictions. They all agree, and they all sit in it together, and will actually tend to obey them. And like you said, if the minister if the Prime Minister goes out and sits out in the cafe when everybody else is not allowed to, I mean, that kind of confusing messages doesn't make people obey. I mean, that doesn't make people trust leadership. And I think in this situation, for such a long time, we need to have someone we can believe in.
We just last remark. Almost 7 years ago, Ukraine as a country did pro-European choice. And we are very young. We are politically very young. We have no European political culture. So we are in a learning process. Ukrainian experts, Ukrainian physicians, they just they start with evidence-based medicine. They start with peer-review publications. So we are in the early beginning of political and professional culture. And our failures, we have these failures. It's a failures of a young country who just we are just in the very beginning of our building ourselves. So probably later I will show you some other presentation, much more optimistic.
Elmin, you had a comment, question?
Yeah, thanks. I realize now that when the question and answer window is open, you can't actually unmute. I was interested to hear how significantly your trauma load was controlled by lockdown. And apart from not allowing people on the beaches, what else was contributing so significantly to the reduction in trauma? Did you also have an alcohol ban like we had, or did people drink at home and not do anything else?
Kiev, fortunately, has a very low level of gunshot and knife wounds. So we are very, very peaceful comparing to, we are a very peaceful country and peaceful city. I try, it's not proven, but I suppose the reducing of trauma cases was related to reducing of traffic accidents. Everything were closed, absolutely. Even the public transportation, even the metro. We stayed at home and we would drink a little bit, but probably, but we didn't interact with other people. So probably this is the real cause of reduction.
Okay, I think we will go to the last formal talk before the last case, and I am pleased to introduce Professor Rifat Latifi. He's chairman of surgery at New York Medical College School of Medicine, and he's director of the Department of Surgery, chief of general surgery at Westchester Medical Center, New York. I actually thought you were still in Arizona, but you're not. But he has been in Arizona. He is the founding president of the Kosovo College of Surgeons, and more recently, he's also the editor-in-chief of the Kosovo Journal of Surgery. He has a broad academic and clinical background, and we are going to hear about telemedicine and telepresence. Now at center stage, but long overdue. And I think this is a very good topic together with, so during the pandemic where presence is not always possible, and it makes it even more actual or hot as a topic. Rifat, please.
Thank you, Tina. Thank you, everyone. I really enjoyed it, the presentations. It's going to be difficult to follow those outstanding presentations, but let me give it a try. I want to talk to you today about a topic that I have been involved for the last 20 years. This is not an advertisement of the books, but I started in 2004 with the first book, and now this last one just came out last month on telemedicine. So it has been a long love of mine because I thought always that makes sense to do telemedicine. So I'm going to try to just describe a couple of benefits of telemedicine, including minimizing patient, provider, and community exposure, outline some strategy for expanding telehealth in the future, and give some examples of international telemedicine. And again, these are a couple of publications that has come out recently on telemedicine, both at the Bulletin of American College of Surgeons, which is freely downloadable, and on a telemedicine journal. No question in my mind that telemedicine is proven to provide rapid, safe, and high-quality care. But these virtual clinics, virtual clinical services did not take center stage until recently, unfortunately, with the coronavirus. So I wrote this editorial on a bulletin and said maybe expansion of telemedicine will be the only good thing that COVID had brought for us. As you can see, I was desperate to have it somehow get more popular, and a lot of you have heard me speaking about this like I'm talking gospel. So I think, and it can be really, the pandemic has reminded us of this, and telepresence can be done really for every condition. From preoperative workup and surgical decision-making can be done through telemedicine as well as post-operative visits. I have done a significant number of operations here in the last few months or last year that I didn't see the patient until the day came to be operated, and didn't see the moment they left the operation. I saw them all virtually. Actually took someone one day through drain removals from a neighbor who was around, because I didn't, it was 4 hours time for someone to go and see a physician in northern New York. Let me just say, frankly, a conclusion here, but I'll keep going on. Because of COVID, the medical community has come to realize that telemedicine is, in fact, is applicable, is desirable, acceptable, and much sought after means for providing healthcare service, first by our patients and finally by the hospital community at large. So it works. Patients are requesting it in our cases. But you know, we all have to be honest with each other. Why do we really need to see the patient physically anyway? So how much do we examine the patient? How much we're looking for ultrasound, we're looking for CT scan, we're looking for everything else, and then eventually, as I have a friend of mine said, if all fails, examine the patient. Or do we actually need them at all? In many cases, I'm not talking about when you get shot in South Africa, you need a doctor there, but many cases really do not need hands-on seeing the patient. And there's a really great editorial on New England Journal of Medicine that was published in early in 2020 by Hollander. It's called Virtually Perfect Telemedicine for COVID. So I think it was given to be good. COVID-19 is likely to create sustained and responsible, I would call it logical, change in human behavior and adaptation attitudes. We all have learned to live differently. When I get out in my garage, I want to put the mask on because now I'm going somewhere else. So we clearly have changed our mind for a lot of things. Patients, especially those with chronic conditions, will prefer and do prefer telemedicine to routine in-person hospital or office visits. We can measure blood pressure, we can see the saturation, we can look at the x-ray if we have, we can listen to the heart, all of this we can do through telemedicine. But there's a caveat. We, the doctors and overall healthcare workers, for that matter, have to transform too and change our mindset. Implementation of telemedicine still needs to be evidence-based. Performance and quality control should be measured, and continuity of care should be ensured. Moreover, telemedicine, in order to gain acceptance, it needs to be tested and used not only during the pandemic, but on a continuing daily basis. So I'm concerned that we will be done with this pandemic and say, let's go back to having 30 patients waiting in a wait room back again the way we do it and we did it before. So hopefully not. So who is responsible, another question, who's responsible for success of telemedicine? As I mentioned, I've been involved in this for a bit and I was trying to figure out why some programs fail and why some programs succeed. So the answer is to clinical champions. It could be clinical, could be an administrator, could be an IT, tech, could be some administrator, someone who a grant donor. So those are really the champions. I took this question to two telemedicine programs that we had created in Albania and in Cabo Verde, Africa. And we got the data from January 14 to 218 and 13 to 18 to ask this question: the role of telemedicine consultation as an indicator of telemedicine champions' contribution, healthcare systems needs, or both. In other way, is it human-driven? Is it because we really need it, and so on? So data were prospectively collected between 2014 and 18 from these two countries that I mentioned, and telemedicine champions were defined as programs, physicians, or hospitals who have contributed at least 100 telemedicine consultations during the study period. So if you've done 20 a year, basically, you were called a champion. So this is a little bit background on this. Nation telemedicine programs in nationwide in Cabo Verde and Albania were built by an international virtual e-hospital foundation. Using this strategy, initiate, build, operate, transfer. So the aim of our study was to compare clinical results between the two programs and see, do they change in any way, shape, or form. This is just a map of Albania telemedicine program. And these are the islands of Cabo Verde, beautiful. I don't need to show to any Europeans this picture, but my friends here sometimes mix things with the different countries. So we have 14 telemedicine centers in Cabo Verde and 44 in Albania. This is just an illustration what we have in Albania. The T stands for transfer, so now it's under the Ministry of Health program. There were 2,442 patients in Cabo Verde in Albania and 2,700 in Albania. We define again 100 teleconsultation benchmark as an indication for telemedicine champions. When we looked in Albania, the indicators, the main clinical champions were radiology, very interesting neurotrauma, and neurology or stroke. On the other hand, in Capo Verde, it was neurology, cardiology, orthopedics, surgery, glad to see this, endocrine, otorhinolaryngology, urology, and dermatology. This is just a picture for both of these champions. And we concluded from this that successful implementation of telemedicine program depend on many factors. Physician champions eventually create clinical discipline champion and represent the hospital champion, or are the backbone of of sustainability and progress of telemedicine, any telemedicine program. The number of consultations, however, reflects the lack of local special expertise to provide healthcare service, and thus can be used by ministers of health and others for future planning and investment. Let me just give you a couple of more examples on telemedicine for neurotrauma in Albania. This is our initial study we published using at the World Neurosurgery. Out of 140 teleconsultations for neurotrauma, we use store and forward or asynchronous, and 84% of the teleconsultations, and live with 15%. Median time of response to teleconsultation was 20 minutes. Now, the way it works, the neurosurgery team on call at University of Tirana Trauma Center sees a CT scan that is uploaded, and they see the patient if they want to, and they decide if the patient needs to be transferred or not. That's the only trauma center in the country. The transfer rate, 34%. It's amazing. 66% of patients did not need transfer to the trauma center. We updated this study later. It got even more. 68.31% did not require transfer to the tertiary center. This is on 590 cases. And most of the teleconsultation actually occurred during the daytime. And most cases of low severity were not transferred. So only those who really needed high-level trauma care were transferred to the trauma center. So in conclusion with this, structured and coordinated telemedicine for neurotrauma increases access to care for neurosurgery patients in countries that do not have widespread neurosurgery services. Nearly 70% of patients, as in these both studies, may be treated locally by non-neurosurgeons. One of the biggest problems that we in our trauma center here is babysitting neurosurgery patients all night long with no really need to even come to see us. So I think we can conclude from these two countries that telemedicine increases access to care through in any discipline, and now has been shown clearly by many other studies. There's a gap, however, in the literature and controversy, but perhaps somewhat underreported, and very little to no clinical data from the surgery. So we are in a process of this. This is just a project that we are in the process of trying to figure out the rationale behind trying to do a study how to contribute to the current evidence and based practice. Our aim is to evaluate the current body of evidence from expert opinions, qualitative and quantitative reports on the current use of future directions in implementation of telemedicine, surgery, and surgical specialties during COVID-19. We have a bunch of research questions. We'll do any reports anywhere where intervention with telemedicine was used, outcomes, timing, and settings in or as an outpatient. We are approved, did not need the IRB approval. We published the protocol on the International Journal of Surgery Protocols. This is a scoping device, and we used the PRISMA statement extension. These are just statistical stuff, and this is a long thing, but we reviewed about almost 3,000 records. Eventually, we're going to have about 203 papers that we're going to review for the study. So I'm coming to the end. I think when it comes to telemedicine, not just for COVID, but others, but particularly nowadays, we can perform close monitoring of medication and outcomes, care for those needing constant surveillance, remote chemotherapy supervision, symptom management, survivorship care, palliative care, and clinical trials, as well as rapid triage and so on. And finally, we can really do peri-operative management completely once the patient at home. You can use this for basically for liver transplant and other stuff. So in the results, there are 76 publications, perspectives to and forward and consult pre-op assessment, determining urgency, and so on. The thing that I just saw. There are a few challenges though, and I will just summarize them quickly. Not everyone has broadband connection. Even in the United States, in the state of New York, I have plenty of patients who live upstate, which is absolutely gorgeous to live there, but they have a phone on the wall. They don't have a cell phone. They don't have a computer, so it's somewhat difficult to do that. And then HIPAA compliant software to connect both sides. I think the only reason that we are now more set into telemedicine is the use of software that actually can connect us easily, just like we are having a conversation tonight here from all corners of the world. And we need to do training and credentialing of the platform on both sides, and some medical legal reimbursement issues have been addressed actually by the United States government. Now the insurance will pay for telemedicine consults, which is, for me, it was always no issue. However, now at least folks are getting paid for these exams. So it really has become much more popular than before, but need further integration into the healthcare system, and the role of telemedicine is clearly increasing. We, the clinicians, the patient, the hospital administration, policymakers, insurance companies, blah, 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 industry and other related parties are seeing this use of telehealth in as much as we can to integrate in the healthcare. Thank you very much, and I'll be very happy to answer any question.
Thank you so much, Rifat. That is impressive, and I'm sure there will be more use of telemedicine after, during, and after the pandemic. Definitely, even if at some stage I don't agree with everything can be done by telemedicine. I think there is still a role for presence and hands-on, definitely, but it has been overused. Any comments, questions from the others? I don't think there was any specific. Yeah, Elmin, are you able to unmute again?
Yep. I'm just interested in knowing what kind of equipment, apart from good internet, is needed. So a patient who would be typically a new case for telemedicine assessment, does he go to a clinic? Is there already somebody who's done the blood pressure? Is there blood test capability? Are we talking about somebody who's sitting at home consulting the specialist, or are we talking about somebody consulting from an environment where there is technology already?
Well, both. Both of those are acceptable. In the past, we did not have, when I was at University of Arizona, we had created a tele-trauma program, and because we had a huge telemedicine program, people had to go to a spa, to a place, because we did not have mobile devices that we could do that. I think it's really important that we connect with the primary care physicians so they can go there if they need a telemedicine consult for a surgical problem. But a lot of patients are actually, we see them, not as many patients first time, but we see them as in a follow-up. So the first time they want to come and meet the surgeon if they have a, I do a lot of complex abdominal reconstruction, so they want to see that. Some of them they have been seen by many surgeons already, and they refuse to operate on them or whatever. And you see they have a cell phone, even if it's not high quality, you see massive hernia. So that's really nothing you're going to do differently. You're going to say, go and see cardiologist. And if you get clearance, you come in, or you bring in a day before in the hospital, and you clear them and you operate next morning. So a lot of people now have mobile telephones and so on that you can use, or iPads. Some folks have given iPads to patients, and they put a software on them, and they had mobile devices to measure blood pressure, temperature, saturation. You can see directly. So when there is a will, there is a way to do this.
Okay. Then I do think, in the interest of time, we were promised a second case that I postponed from the beginning of the meeting until now, and I'm curious about the case. So I'm going to allow Steve to run the second case as the last thing before we wrap up. I think this is the meeting has been with lots of input from different aspects, and we could spend a long time discussing all of them. I'm going to allow Steve to have the attention. I don't want your Excel sheets.
Can you see it very clearly?
Yes, but you're not on slide. You need to put up the slide.
I'm going to do just that. As soon as I have this undone, I'll try and keep it safe, and then we will keep it to the point. Just 1 second. Okay, slideshow. Okay, thank you. Just a small one. This is a Mr. AM, multiple gunshots. If anybody knows our country, this area of Hillbrow is one of the areas that consistently supplies us with very good cases for learning purposes, etc. But you can see there again, this is a slightly different patient. You can see multiple gunshots, and you see 4 bullets. This patient was shot while he was seated in the car. He dropped his systolic blood pressure to 65. His base excess, his lactates are much more worse, and he's obviously cold and clammy, and he's becoming less responsive. No doubt, you can see some more gunshots around the upper chest as well, and you see 2 more wounds in front. So all of his 4 gunshot wounds, all of them anterior chest as well as anterior abdomen, have got retained bullets inside the abdomen. I'm just not going to say too much about this, but in his case, there was no fluid around his heart, a bit of a pneumothorax. And again, this was done within 5 minutes on the way to theater. Did not stop anything else from theater. If you look very carefully at the back, one of the bullets has gone from anterior and is sitting at the back, and all of them have crossed from anterior to the back. No obvious significant pericardial fluid, no obvious significant pelvic fluid, and certainly again another thoracoabdominal injury. I'm sure you will be worried to find this picture where you can see that one of the epigastric gunshots has ended up with a bullet that is just lying in front of or just above the pancreas. And I'm sure most of us, we would like to take him to theater and do something about it. It comes back to this question, which cavity first? And certainly we had competing cavities in this case. There was no doubt about the abdomen. There was associated chest, and we needed to make a quick damage control decision and take him to theater. So he had a laparotomy, he had a liver repair. We had just a bullet that had just gone above the pancreas on an area around the neck of the pancreas, and we left the drain in the pancreas. Immediately after that, compared to the other patient, we went straight to thoracotomy on the left side. We repaired the lung, and lo and behold, irrespective of lack of significant fluid around the pericardium, there was an injury to the atrium from one of the parasternal gunshot, and you had about 3 bullets that were removed in theater. What this patient has realized and has brought us back to, unfortunately, with all of these lung injuries, with all of these attitudes and approaches that we have for lung thoracotomy, you ended up with associated multiple injuries of the lung. So at least 2 of the bullets that were at parasternal had damaged the lung, and one of them on its way out had damaged this atrium and had to be operated on. And it came up again with that issue of exposure as a healthcare worker to all of this air in a patient that was COVID positive. I don't know about you, most of our COVID positive patients in South African context of trauma, they don't tend to always have a difficult COVID period. It's usually that they seem to be positive with the trauma seems to be the main presenting symptom, and the cause of positive COVID status has not always interfered with the management of care. And you can see the wounds a little bit closely. And those 2 wounds that you see parasternal, the lower one damaged the lower lobe as well as the atrium, and the upper one had managed to damage the middle lobe, and then there were other extremity injuries in this case. But he brought out a lot of issues around what do we do differently? How do we make sure that we get higher control and not expose each other to the rest of COVID? And how to make sure that our standards of covering ourselves as surgeons when we operate and assuming that they are COVID positive throughout the operation while you're waiting the results is a safe way to approach a case like this. He otherwise overall did reasonably well. We never ran into major problems with his ventilation except for restlessness. He never had pulmonary presentation of associated lung involvement of the COVID. He had a mild effusion that was related to the trauma, but all of this improved very well with conservative management, and he was ultimately discharged out of the hospital with an associated pneumonia and some mild parapneumonic effusion, but this patient did very well. And again, he gave us all of those concerns around how to deal with COVID, how to change our mindset towards COVID, and ultimately he was discharged from the hospital perspective. I just want to mention that we were not able to retrieve this bullet. His pancreas never gave us any complications. From the surface, it seems to have gone on the upper body of the pancreas, but it had not damaged either the aorta, and follow-up of the investigation of the aorta, this area we were not able to deal with it in any other different way. And he's continued to do well. His limbs were also sorted out and managed, and lo and behold, again, another case that again with COVID on top of what we're dealing with difficult thoracoabdominal injuries, have forced us to work outside the usual realm of care and management, and still have been able to have a successful combined laparotomy and thoracotomy with the very same surgeons, and able to have an appropriate and a successful outcome. I think I'm going to stop there in the interest of time, and thank you very much for your attention and to be able to move on in terms of the way forward. Thank you.
Thank you. That was very efficient, Steve. Very nice case. And I think we are going to, since we're running over time, I'm just going to wrap up and close. And I'm going to thank all the speakers. Different aspects have been described. And I think I want to quote Elmin, what she said in the beginning. I think in this challenging period, more than difference between different categories of countries, it's more how we use our resources. I think we've all been met with that during the pandemic. That it depends on the volume of patients, it depends on how we actually prioritize and so on. But we have the obligation, all of us, to maintain trauma care as well as possible, and I think it is possible. It was a very nice, optimistic last case, and congratulations with the case, Steve. I'm just going to say thank you all for being here, and hope to see you all soon. Not by telemedicine, but real life. Okay, thank you all for coming.
Thank you.
Thank you.
Thank you so much, everyone. Have a good one. Bye-bye.
Thank you.